Okay, so we'll be discussing the test of coagulation and the physiology that pertains to it. So firstly, I'd just like to say that, you know, what we've been taught in medical school is the old model of what coagulation is, and that involves primary hemostasis as well as secondary hemostasis. But there's a new model that refers to the cell-based model, and this is basically what the point of care testing, like your thromboelastogram and your rotum, is used. But it's still very important for us to know what the old model is, like primary hemostasis and secondary hemostasis, because it pertains to the tests that we use commonly, you know, everyday tests. So primary hemostasis, this is mainly platelets, and hemostasis is just the physiological process which stops bleeding, and it happens in 4 phases. The first phase is that you get adhesion. So when we have trauma, you have your collagen that will be exposed, and your platelets will bind either directly or indirectly to your endothelial cells on that collagen that is exposed. Directly, they will bind by glycoprotein 1A with factor 2, so activated factor 2. And indirectly, they will bind with von Willebrand's factor. And von Willebrand's factor is just a subtype of a cofactor that we have, which is factor 8. And you'll see later when we do the coagulation cascade that factor 8 is also within the coagulation cascade. So it will indirectly, your platelets will indirectly bind with the von Willebrand's factor, with your glycoprotein 2B, as well as factor 9 receptor. So that's your first phase, your adhesion. And then you have the second phase, which is activation. So once your platelets are actually bound onto your cells, they then just change the shape from this disc-shaped platelets into a spherical shape. And when they change their shape, they release factors, which will further activate more platelets to come. And the factors that they will release will be your ADP, fibrinogen, thromboxane, as well as serotonin. So when they bound and they change the spherical shape, they then just enhance their bound to your endothelial cells with these pseudopods. So it's still the same factors and still the same glycoprotein with the von Willebrand's factors that will bind onto your endothelial cells and your collagens, but it's more sturdious with the pseudopod binding. So then, as I said, is that with the activation, your platelets will release certain proteins or agonists like thromboxane, ADP, serotonin, and this will cause more platelet aggregation. So, which is your third phase, platelet aggregation. Your platelets will come and they will bind to each other by the glycoprotein 2B and activated factor 3, as well as glycoprotein, so 2 glycoprotein 2Bs on either platelet cell. And what will stabilize that bind is your fibrinogen. So your fibrinogen is, classically we know, is the product of your coagulation cascade. And that will come in play in the third phase of your primary hemostasis to bind those platelets together. And then the fourth phase will be your stabilization of your platelet plug. So what happens here is that you get your thrombin hydrolysis of your arginine-glycine bonds of your fibrinogen to form fibrin monomers. Né? And these fibrin monomers are like fibrinopeptide A and B's and C's and D's and so forth. And what links these are really loose bonds. Né? They loose hydrogen bonds, as you can see there on that diagram. But you need something to really strengthen those bonds. And to get that, you have to activate your factor 13. And that strengthens those hydrogen bonds to transamidase bonds that forms fibrin polymers. And that's how you're able to get like a strong form of your platelet plug with your cross-linked fibrinogen. So just on the side here, you'll see there's two types of von Willebrand factor. So the one that I was talking about is the one that is synthesized by your endothelial cells, and that is involved in primary hemostasis, or what we know, what we historically knew, of how hemostasis goes by in primary hemostasis. And it's very important for platelet endothelial cell interaction with your glycoprotein 1b and your factor 9, as well as your glycoprotein 2b and your activated factor 3 receptors. And then the other factor 8, which is your factor 8c, that is synthesized by your liver. And you'll see that that is the one that we see mainly in the coagulation cascade. Okay, so secondary hemostasis or coagulation cascade, as we know, is your intrinsic and your extrinsic pathway. So your intrinsic pathway, you'll see on the left there, it's activated by contact with negatively charged surfaces collagen and subendothelial connective tissue. And this contact is actually independent of calcium. So most of these reactions actually happen with calcium and phospholipid, but this one in particular, it's independent with calcium, and it usually happens in vivo. So you need prekallikrein. So prekallikrein is another clotting factor, which is actually important for us to know, because one of our antifibrinolytics work by inhibiting the product of prekallikrein, so kallikrein, which we'll get to a bit later. So prekallikrein will then activate factor 12. Factor 12 will then activate factor 10 with the use of a cofactor high molecular weight factor. And this activated factor 11 will activate factor 9 until you get to your complex, which is your tenase complex. Né? And tenase, because you are activating factor 10. And to activate factor 10, you need cofactor like factor 8. This is then your factor 8C, which is different from in your primary hemostasis, which is your factor 8 von Willebrand factor. Okay. And for this process to happen, you need calcium and phospholipid. And that is your intrinsic pathway. So the product of your intrinsic pathway will be your activated factor 10 via your tenase complex. And then your extrinsic pathway occurs when you have trauma. So when you have trauma, you've got your tissue factor is exposed. Then the name of tissue factor is also tissue thromboplastin or factor 3. And what this does, it will activate factor 7. So activated factor 7 with the use of calcium and phospholipids will activate factor 10, which is the same product of what you got in your intrinsic factor, right? Pathway. And then you finally get to your common pathway. So with common pathway, you have activated factor 10, and this complex we call the prothrombinase complex. Prothrombinase complex because the byproduct of this complex is thrombin. Tenase complex, the byproduct of that complex is factor 10. So the prothrombinase complex, it needs activated factor 10 with a cofactor, factor 5, with your calcium and your phospholipid to activate prothrombin to your thrombin. And then that's when you get your thrombin that will basically just strengthen your fibrinogen bondage so that you can have stable fibrin to then bind onto your platelets. All of this, your primary hemostasis and your secondary hemostasis is what we all know in med school of what hemostasis is. But in real life, like it doesn't work. It doesn't happen independent of each other. Like your cells don't work independent of your clotting factors. Everything works in like together. And that is what the cell-based model is made of. But it's still very important for us to know this. So you need to know it. So now that we know, does anyone have any questions? So that we can move on. Okay. I'm guessing silence is not questions. Okay, so I have a question for you. So what are the physiological inhibitors of coagulation? So we know what are the clotting factors of coagulation, but what are the physiological inhibitors? What inhibits all of this coagulation cascade? Anyone can answer?
Hi, Dr. Milan.
Hi.
It's antithrombin 3, protein S, and protein C.
Good. Good. It's right on the screen. Thank you. Antithrombin 3, activated protein C and S, as well as tissue factor pathway inhibitor. Very well done. Now the next question I have for you guys is unfractionated heparin. So what's the mode of action of it and how do we monitor it? Sorry? Anyone? Anyone want to try what the mode of action is of unfractionated heparin?
Hi, Doc.
Hi.
Yeah, so
Hello.
yes, I think it acts by inhibiting no, it actually works on antithrombin 3.
Good. So it potentiates the activity of antithrombin 3.
Antithrombin 3, yes.
Good. Well done. So it potentiates the effect of antithrombin 3, and then what's the effect of antithrombin 3? What does antithrombin 3 inhibit?
So antithrombin 3 inhibits the activated factor 10 and activated factor 2, which is thrombin.
Good, well done. So how do we monitor it? What test can we use to monitor unfractionated heparin?
Is it the aPTT?
Yeah, we can use aPTT. What else? We can use activated clotting time as well as INR. Okay, so what must your INR be on a patient who you've given unfractionated heparin to before you can do a spinal on that patient?
I think INR must be less than 1.5.
Good, well done. And how do we, what's the antidote if we give too much?
Protamine sulfate.
Yes, excellent. So enoxaparin, another name for it is clexane. So what's the mode of action of clexane? Anyone else can try? Okay, so clexane, basically, with unfractionated heparin, the molecular structure of it is quite long. So that's why it's able to potentiate the effect of thrombin through inhibiting activated factor 10 as well. I mean, potentiate the effect of antithrombin 3 to inhibit the effects of activated factor 10 as well as thrombin. However, because it's long, it has a lot of side effects. So they've then created a form of the drug which is much shorter. And because it's shorter, it will have less side effects, but then it will inhibit less things. So it also, clexane will potentiate the effect of antithrombin 3. However, because the drug itself is quite short, it will only inhibit activated factor 10. So that's the difference, okay? So this one potentiates activated antithrombin 3 by inhibiting activated factor 10 only. And how we monitor it is a anti-10A assay, but these monitoring are very expensive. I've never actually seen it. Okay, warfarin. What's the mode of action of warfarin? Anyone can try mode of action of warfarin? Okay, so warfarin is a, yeah, yes.
Hi, Dr. Nolan.
Hi.
Can you, Hi, Dr. Nolan.
Yes, man.
Oh, it completely inhibits the vitamin K reductase enzyme, which essentially activates vitamin K.
Good. Therefore, so you're completely right, Begine. So therefore, it inhibits your vitamin K dependent factors, which are your vitamin K dependent factors?
They are factor 10, 9, 7, and 2.
Good, well done. Okay, how do we monitor it? How do we monitor warfarin?
INR.
Yes. And then if we have an overdose of warfarin, what's our antidote? What can we give a patient who has an overdose of warfarin, who has a coagulopathy because there's an overdose of warfarin? Immediately, what can we give?
FFPs.
Yes, well done. An alternative, which is more expensive, but it's more direct to all the factors that you have. What's an alternative?
It's the prothrombin complex C.
Yes, PCC, prothrombin complex concentrate. It has all those vitamin K dependent factors, factor 2, 7, 9, as well as 10. Good, guys. Let's move on. Okay, so your intrinsic factor, how we can monitor it with our static monitors, you do your activated partial thromboplastin time. And basically you take blood, you send it to the lab, and they add calcium phospholipids and an external clotting factor, which is kaolin, and they look at the time at which your blood will clot. And the normal amount of it to clot is 25 to 35 seconds. If it's prolonged, it can mean that you have an overdose on unfractionated heparin. Your patient has hemophilia, sorry for the type of hemophilia A, so deficiency of your factor 8, or there's DIC because of overconsumption. And then your prothrombin time, it looks at your extrinsic factor. You basically will take blood, and it looks for the time required for your fibrin clot formation. You send it to the lab, they add calcium and thromboplastin. And then they look at the time for it to clot. The usual amount of time for it is 16 to 18 seconds. Né? But sometimes thromboplastin is not always present in your labs. So therefore, they have to have a corrected prothrombin time. And this is where your INR comes in. So this, the corrected prothrombin time is your INR. So if this PT is prolonged, you have it's either deficiency in your vitamin K dependent factors, or by warfarin overdose, or by liver disease. Okay, and then how we test for the common pathway, we look at the thrombin time. So you take blood, you send it to a lab, they add bovine thrombin, so like from a pig, and normal time for it to clot is 14 to 16 seconds. And if it was prolonged, it will mean that you have a fibrinogen deficiency. Okay, so the advantage of these tests is that they're cheap, they're really easy to interpret. You can use them to monitor drugs, like you guys have rightfully said. It measures your protein interaction with your plasma, and it measures the adequacy of clotting factors. But, you know, the limitations is that it uses static endpoints. It really ignores your altered thrombin generation. It ignores your cellular elements completely. And we know that clotting is more than just, clotting factors. You need your cells there as well. It ignores your overall clot structure. The turnaround time is very, very long. I mean, to get an INR and aPTT and aPTT is very long. And if you have a patient that's bleeding right now and you need to know what the coagulation status of the patient is and what you need to give, you need to have an alternative. So it doesn't really guide you for blood or blood products. And that's why we go with our cell-based model. So the cell-based model itself is not something that's commonly asked in the DA. I don't know about the new exams that they'll have, but it is a primary topic, and they usually just ask you what factors are involved in each of the phases. So there's 3 different phases. There's initiation, first phase. Second is amplification phase, and the third is propagation phase. You just need to know something about it because you have to know what the TEG is. And the thromboelastogram works on this model. So when you have the initiation phase, you have tissue-bearing cells that are outside, your vascular wall. So when the blood cell is damaged, you'll have your factor 2, factor 7, and your factor 10. They will leave these damaged blood cells, and they will travel to tissue factor-bearing cells. So these tissue factor-bearing cells, there's 4 different cells. There's fibroblasts, endothelial cells, macrophages, and mononuclear cells. And then when activated factor 7 binds with this tissue factor-bearing cells, they will activate factor 10. And then activated factor 10 will then promote a small amount of thrombin, as you can see there. So 2A, activated factor 2, thrombin only in small amounts. Yeah. And then this small amounts of thrombin will then go on to your amplification phase. And in your amplification phase, starts with your tissue factor-bearing cells are then exposed to your platelets, your von Willebrand factors, as well as your factor 8. And your thrombin will activate your platelets to form a platelet plug. These platelets will then further be activated and be primed by other cofactors, like activated factor 5, activated factor 8, and activated factor 11. And these activated factor 7 with your tissue factor-bearing cells, as well as your activated factor 11 will activate factor, as well as the activated factor 11 will activate factor 9. Okay, so that's your amplification phase. So the byproduct of that is that you want activated factor 9. Then this activated factor 9 goes on to your propagation phase, where you activated factor 9 will form a 10A's complex with your cofactor, activated factor 8, and activate your factor 10 in the presence of all these activated platelets to form activated factor 10 and a large amount of factor 2. And that is your propagation phase where you get your thrombin burst. And this thrombin burst will act as a positive feedback mechanism to further activate all the factors that prime your platelets. Okay, I know this is quite a lot to process, but basically you just need to know that the cell-based model is what happens in vitro, that your clotting factors work together with your cells to form this large amount of fibrin, thrombin, and then you get your fibrinogen, which will then be strengthened by your activated factor 13 to form a very good platelet plug. Any questions on this? Can I move on? Let me move on then. So the difference is that the clotting cascade, it's in vitro and in vivo testing of clotting factors, and the cell-based model is in vivo, so inside testing clotting factors. Clotting cascade is based on the amount of clotting factors available, where the cell-based model is based on the amount and the quality of the clotting factors. The clotting cascade, it does not take into account of interaction with your tissue factor-bearing cells, which we said were fibroblasts, F, fibroblasts, E, endothelial cells, macrophages, as well as mononuclear cells. And the cell-based model includes your platelets and your tissue factor-bearing cells in hemostasis. Clotting cascade, it does not better reflect real-time clotting, whereas your cell-based model, it better reflects, your clotting at that time. So that's why we can use it as a point of care testing when you have a patient who has coagulopathy. Okay, so enough about coagulation. Let's look a little bit about fibrinolysis. So your plasminogen, it's a beta globulin, and that's found in your tissue. And it's converted to plasmin by your vessel wall activators. No? And then your plasmin will then break down fibrin and fibrinogen to fibrin degradation products. And as you can see, there's this fibrin degradation products, E, D, Y, D, yeah. Those are all of the products that are produced. So there are two classes of antifibrinolytics that we know of. Does anyone know of those classes? And can anyone name examples of them? Or name any antifibrolytic that you use in your practice. Anything. What antifibrinolytic do you use?
TXA.
Yes. So do you know what class it is, Becky?
It is
Does everyone know what TXA is first? He used it in abbreviation form.
It's a tranexamic acid. Sorry.
Yeah, good. So what class is it? And the generic name that we know?
It's cyclocapron.
Yes, good. The class?
Eindislibel. I think Eindislibel.
Yeah, that's fine. So it's an amino acid. And the
Oh.
other Yeah, so the other example we have is EARCAs, so the epsilon aminocaproic acid, but they're not commonly used. And then the second class we also have is your serine protease inhibitors, and they work on, if you remember when we were doing the intrinsic pathway and we spoke about prekallikrein. So what serine protease inhibitors, they will inhibit the activated form of prekallikrein, so kallikrein, in order to cause fibrinolysis. Okay, so now we're getting to the TEG itself. Please pay attention to this because I will ask you to interpret some examples. If there's anything that you don't understand, please, you're welcome to stop me and I can help just explain it further. So this is the TEG, the thromboelastogram. I think we still have it in our ICU. This is exactly how it looks like on the left side. On the right side, those are its cartridges. Cartridges must be kept refrigerated. They're also very expensive. They are about 2,000 Rand per cartridge, so you need to use it sparingly. And how it works is this diagram. We have this cup, né? This cup that oscillates with blood inside, and this pin that is attached to a taut wire and a transducer with a heating element. So you basically pour saturated blood into the TEG cartridge. So saturated, you need to pour it into a blue tube, no? And you see it needs to be at the level of the marker. And also make sure that the TEG is not, the cartridge of the TEG is not expired, because it really won't work. So this cup will then hold the whole blood and will oscillate to and fro every 10 seconds. And as the clot forms, the torque or the force of rotation of the cup is transmitted to the pin, which is immersed in this blood. Yeah? And then the degree of the pin rotating is converted to an electrical signal via a transducer, and it's monitored via a chart. So the chart is the elastogram. And here we look at the degree of the pin movement. The degree of the pin movement is a function of the clot kinetics. So basically the movement of the clot. And then the magnitude of the pin movement is the function of the mechanical properties of the clot. So cup will oscillate. It's the pin that is torted onto on a wire will then give a drawing. Né? We'll go through what the drawing is. So before we go through what the drawing is, let me just briefly tell you. So advantage of this is that it demonstrates all phases of hemostasis. So the initial fibrin formation, the fibrin platelet construction, and the clot lysis. It identifies imbalance of hemostatic systems, so the risk of bleeding and the risk of thromboembolic events. And it really guides you to giving blood and blood products. And it's quick. The CRT arm, we look at the different arms. It comes out in 10 minutes. Limitations, as I said, it's expensive. It doesn't factor in endothelial glycocalyx, and it actually cannot assess. It assesses the amount of platelets, the adequacy of platelets, but not how well they function. Okay, so this is the crux of the TEG. So that pin will give a drawing, né? And this is how the drawing looks like. It's basically one line, and then it's two lines that separate on each other. And there's different parameters of it. Né? It's the R time that you can see in green, the K time that you can see in blue, the alpha angle that is in yellow, the maximum amplitude you can see in red, and the lysosome 30 that you can see in purple. So the R time in green, this is thrombogenesis. So this time, it tells us the time of formation of the critical mass of fibrin. So if you remember, with the coagulation cascade, what you need for fibrin to form, you need all those clotting factors. Clotting factors are the intrinsic and the extrinsic factors, right? So if you do not have enough of those clotting factors, it means that your R time will be prolonged. And then if it is prolonged, it means that you need to give the patient clotting factors. And what blood product can we give when we don't have enough clotting factors? Okay, the answer is right there. It's FFPs, né? And the doses we give is 10 to 15 mils per kg. And if our R time is short, it means there's too much clotting factors. So your patient is in a hypercoagulable state. Did everyone understand the R time? Yes or no?
Yes, though.
Cool. So K time then looks at the beginning of movement of the pin until the 20th millimeter width, né? And it's a marker of presence of the fibrinogen production. So if your K time is prolonged, it means that you do not have enough fibrinogen. So you need to give a blood product that has fibrinogen in it. And we know that cryoprecipitate has fibrinogen in it. And the dose of cryoprecipitate is you give 1 unit. It's usually like 10 mils. It's a very small amount. You give 1 unit per 10 kgs of the patient. So if you have a patient that weighs like 70 kgs, you'll give 7 cryos. Okay? So that's the K time, the blue time, right? And then we're going to the alpha angle. So the alpha angle, it looks at the rate of fibrinogen buildup. Yeah? If you have a small angle, it means there's not enough fibrinogen for it to build up. So you need to give fibrinogen. Again, we know that fibrinogen is in cryoprecipitate. So you'll give it at 1 unit per 10 kg of the patient. And if it's large, it's a fast rate of fibrinogen. There's too much fibrinogen. Okay, did everyone understand the K time and the alpha angle? So those are the main markers of fibrinogen. R time is clotting factors, K time, alpha angle, fibrinogen. Okay, I'm assuming silence is understanding. Then you look at your maximum amplitude, né? So your maximum amplitude is the strength of the clot. So your clot, 80% of it is your platelets and 20% of it is your fibrinogen. So the majority of it is your platelets. So if your maximum amplitude is too small, you do not have enough platelets. So you need to give the patient platelets. And if it's too large, you are hypercoagulable. Okay, so the main functions of fibrinogen will be your K time, your alpha angle, and maximum amplitude. However, your K time is less resistance to the changes of your maximum amplitude. So I would say the one that really would test your fibrinogen is probably your K time. Okay, then you look at your lysosome. Did everyone understand the maximum amplitude? All right, so then you look at your lysosome 30. And this is the percentage decrease in amplitude of pin oscillating 30 minutes after your maximum amplitude is reached. Né? And the reduction of the pin movement gives us an indication of the stability of the strength, which depends on the extent of your fibrinolysis. Okay, so when it's primary, it's a percentage decrease is quite large, right? So you have excess rate of fibrinolysis. You have high levels of your plasminogen activator factor, and that's when you need to give your fibrinolytic agents that we spoke about. And then secondary is there's a small percentage decrease. And that's a rapid rate of clot formation. And the possible cause of that could be your DIC. Okay, so I hope everyone understood this, because now you're going to be interpreting. So before we actually interpret, so you'll see at the top, so this is a strip, this is the tag taken from a patient who had antepartum hemorrhage secondary to a rupture of placenta, and she continued to just bleed postpartumly. So you can see at the top, you have those variables that I spoke about, R time, K time, and the alpha angle, maximum amplitude, and the lysosome 30. I'm just going to explain what we have on the left here before I ask one of you to just interpret this take for us. Okay, so what we have on the left here, basically with all those cartridges, you put in, you put in a clotting factor, an external clotting factor like kaolin. So kaolin, it's actually a clay. It's a clay that stops one from bleeding. So they put it in these cartridges, small amount, and in the CK arm, yeah, it's your citrate kaolin arm. It takes about 30 minutes to get this arm out, okay? So you get your hydrated aluminium with crystal-like structures. It works as a surface activator. So kaolin is like a surface activator, né? It activates factor 12 platelets, and it stimulates the reserve clotting ability of the blood. So by doing this, it just shortens the time and reduces variability. It shortens the time for you to actually get a clot and reduces variability. So the CK arm is actually the most accurate arm, but it takes about 30 minutes to come out. And if you have a patient that's bleeding on the table right now, you want something that's shorter, right? And that then you have your CRT time, which is your citrated rapid take. And this just doubles the amount of activated there is, so kaolin. So it's double of the amount, and it comes out pretty fast. It comes out within 10 minutes, you'll have those results, but it's not as accurate as the CK. And then the other arm you have is your citrate kaolin and your heparinase. So this arm, it has a substance that will inhibit heparin, right? So there's certain cases that you'll do later on in life that will need like constant heparin. Yeah, you need to give the patient constantly heparin, like open heart surgery and bypass surgery. And you really don't know, you won't really know if is the patient bleeding because of coagulopathy, or are they bleeding because you just overdosed them with heparin? So this arm, the CKH arm, will help you out. Né? So basically, if you see that the patient's hypocoagulable, né, with a prolonged R time in your CK, okay? So if your R time is your CK is prolonged and you're not sure, and you know it's a patient that you've been using heparin in, you're not sure if the patient's hypocoagulable because they're bleeding or they're in DIC, or you've used heparin, then you need to look at the CKH arm. If this is normal, then your hypercoagulation is due to over-heparinization. Because remember, this arm will inhibit your heparin. Okay, and then your last one, you see FF, it's a presence of fibrinolysis, inhibiting platelet aggregation that will bind to your glycoprotein receptors. Okay, I hope you guys understood that. Nah? Now, can someone, yeah, so this CK accurate, CRT fast, CKH over-heparinized, fibrinogen in your CFF arm. So anyone, apart from Ubegi, and I'm not really sure who else was answering, anyone else would you like to try and interpret? Just go step by step what the R time means and tell me what each R means. So we're going to interpret the CK time. So the one that's on the top, the one that's most accurate. Just tell me if the R time is prolonged or shortened, and if it's prolonged, what it is, what it means, and what we need to give the patient. Would anyone like to try?
Yes, I would like to try.
Yeah, go for it.
My name is Bridget.
Hi, Bridget.
So what we see with our time, we see that it's 15.6. So it is prolonged because the normal is between 4.6 to 9.1 seconds. So that means it took a long time for the clot to form. So it means we do not have enough fibrin.
Is it fibrin that we don't have enough? Or is it something else?
We don't have enough clotting factors, sorry.
Yes, good, well done.
Yeah. Yes, so then the treatment for that, since we do not have enough clotting factors, will be fresh frozen plasma.
Yes, what's the dose of our
So-
aPTTs?
Okay, so it will be 10 to 15 mils per kg.
Good, well done. And then our K time?
So our K time basically takes, it represents the time it takes for the clot to form. So because it's prolonged also, so it means we don't have enough fibrinogen.
Yes.
Yeah.
So what do we
So
do?
the treatment for that will be cryoprecipitate.
Good, what's the dose of our cryos?
So the dose of cryoprecipitate will be 1 unit per kg of the patient's weight. One unit of cryoprecipitate, yeah.
Per 10 kgs.
Per 10 kgs, yes.
Yes. So if you have a patient that weighs 80 kilograms, you'll give 8 units. But I know some people just always give a blanket of 10, but that's a lot of products, man. Like these blood products are very expensive. The dose is 1 unit per 10 kgs of the patient's weight. Okay, the alpha angle.
So the alpha angle represents the rate in which the fibrinogen builds up. So here we can see that the rate was shorter. So there was not enough time for the buildup. So it means also we don't have enough fibrinogen here as well.
Good, excellent. And the maximum amplitude?
Okay, maximum amplitude is basically about the strength of the clot. So here it is reduced. So the time is shorter, 21.3. So it means we don't have enough platelets to be able to form the clot.
Good. So we'll give platelets to this patient. Good. Well done.
Yes.
So with this patient, I mean, we did a massive transfusion for this patient. I think 2 massive transfusions. Okay, excellent. And then did everyone understand that? I'm going to take silence as everyone understanding it. And then this is the image that we got from the TIG itself. And then would anyone like to try the second one? So this is of a 16-year-old with adolescent idiopathic scoliosis. The patient, so when they dissect, like that's when they bleed a lot. The patient bled about 1 liter in 10 minutes. So with
Hi, Dr.
Hi. So we can
maybe
the CK one. Hello?
May you please go back to the previous slide?
Oh, sure, no problem.
So my the question I wanted to ask is, now that we've interpreted this, what is the overall diagnosis for this patient now? concerning this?
So the
T-
patient, yeah. So the patient is in a hypocoagulable state, né? And they're not even clotting. I don't know if you see that we don't even have a lysosome 30. So the patient is literally, they don't have any clotting factors, no fibrinogen. They're just bleeding. So we need to give fibrinogen. So we need to give clotting factors and fibrinogen and platelets for the patient to even clot. Okay, it's DIC.
Yeah, okay.
Yeah.
Early or late?
Late.
Okay, thank you, Dr. Kumara.
Sure. Okay, anyone want to interpret the next one? Anyone at all?
Okay, it's Bridget again.
Go for it, Bridget.
Okay, so this one, the uptime, it's shorter now. So then
Want to check
it means,
again? Are you sure it's shorter?
oh no, it's normal. It's normal. So it's 7.2. So the time is between 4.6. Yeah. So it's all right. Yes.
Okay. Yeah.
All right. Mm. And now the K time. So the K time it's more. So it's prolonged because it's 3.2. So it means it took long for. So I think here it means we have a hypercoagulable state because it took. What am I saying?
So
Now,
just
let me
like,
think about.
no, it's fine.
No, you can go ahead, Doc.
So just like the previous patient, just interpreted exactly like you did with the previous patient. So it's a longer K time. We know that K time is related to your fibrinogen, right? So if it is prolonged, it means that you don't have enough fibrinogen. Okay. Do you understand that, Bridget? Okay, we lost Bridget. So with this patient, the R time is fine. So there wasn't really a need to give this patient FFPs, but we did anyway. Because we gave it before we actually saw this this take. But there was definitely a need to give this patient fibrinogen, as evident by the prolonged K angle, K time, and the short alpha angle. And there was definitely a need to give this patient some platelets, as we did, as evident by the shortened maximum amplitude. However, we didn't wait for too long for us to get our lysosome 30. That's why you won't see that you won't see that value there. But the patient did clot eventually. He stopped bleeding. Okay, so that is how you interpret a take. Does anyone have any questions before we move on to the ROTEM? Okay, so your ROTEM is your rotational thromboelastometry. And the difference between this, and I mean, it's the same thing, but the only difference is that instead of the cup oscillating, it's your actual pin that's oscillating. And you have the light that's shined from a light diode, and it's reflected onto a detector, and the message is sent via this detector and onto an image, and this pin will rotate every 6 seconds. And it measures as the clot becomes stronger and there's resistance to the rotation of the pin. The only limitation of the standard Rotem is its analysis is the inability to measure the platelet adhesion defects of aspirin-like defects that can be seen during primary hemostasis. So the different parameters of the Rotem are similar actually to your take, but they just named different things. So instead of your R time, you get your clotting time in a Rotem. Instead of your K time, you get your clot formation time. And your alpha angle remains the same, and then it just has 2 more amplitudes, like your amplitude 10 minutes that you reach after your clotting time, just 1 extra one. And then your maximum amplitude will correlate with your maximum clot firmness, your MCF. And then your lysis 30 correlates with your lysis 30 of a TEG. And then this is just a pictorial diagram to show you exactly how the different parameters are. So at the top where you see the black, that's your TEG, R time, K time, alpha angle, maximum amplitude, clotting time. And then your Rotem is your clotting time, your clot formation time, alpha angle, maximum clot, your maximum clot firmness, and your lysosome 30. And with this, it also has different arms, just like in your TEG, you have like your CK and your CRT, your CKH. So the INTEM is basically looks at the intrinsic factor. So it kind of correlates to your PTT, your aPTT. And then your XTEM arm, it will look at your extrinsic factor. So that correlates you to your prothrombin time. And then your HepTem correlates you to your CKH time. So this is when heparin is added. This will be helpful when you have a case where you're using heparin to see if your bleeding is due to overdose of heparin or it's from coagulopathy. And your FibTem is your platelet inhibition. Okay, so that's it. Does anyone have any questions they'd like to ask?